My name is Dr. Govind. I am from the Jayadeva Institute of Cardiovascular Sciences. I am presenting a case of an 11-year-old child who comes from Dharmapuri in Tamil Nadu. Informant is the mother. The history is reliable. Since the history starts from childhood, I would like to start the history from infancy. The mother complains that she first noticed bluish discoloration of the palms and soles and of the oral mucosa and lips starting at 6 months of age. When the child was 6 months of age, she noticed it. The bluish discoloration worsened when the child was crying. And for these complaints, she initially took to a pediatrician. She was advised examination. She was referred to a cardiologist, but the child was not taken to a cardiologist. The child, at 1.5 years of age, child had one episode of abnormal movements of the upper and lower limbs, and which also had there was loss of consciousness. There was no history of fever at that time. With these complaints, the child was taken to a hospital in Tamil Nadu. The child was admitted for a period of 14 days, where the child underwent a scan for the brain, and after that, the treating doctor told that the child will require medications and will not require any surgery for the brain. After that, the child underwent a cardiac evaluation, and therefore the child was referred at 1.5 years to this institute for cardiac evaluation. When the child came to the institute at 1.5 years of age, he underwent an echo scan, and the mother was told that the child will require one surgery at present. She was also counseled that the child will require another surgery in future. The child underwent a surgery through the left side at 1.5 years of age. After this surgery, the mother noticed that there was reduction in the bluish discoloration that persisted for about 1.5 years. The mother was advised to continue certain oral medications and was discharged. After discharge, the mother continued the medications for a period of 1 year, and then she stopped the medications. At about 7 to 8 years of age, the mother noticed that the bluish discoloration was again constant and it appeared. And because of this, she again went to a cardiologist. Again, she was advised to follow up. Again, she was lost to follow up. As the child grew, the mother noticed that the bluish discoloration persisted and also worsened with activity. Child has, since the episode of neurological deficit that the child had at 1.5 years of age, child is unable to walk, he has a limp. Therefore, his activity is per se restricted. But even with restricted activity, if the child walks for a certain distance, he becomes breathless on climbing a few stairs. The mother notes that when he exerts, he stops for a while and then squats, and after squatting and resting for some time, he resumes his activity. There is no history of another episode of seizure after the first one. There is no history of prolonged duration of fever. There is no history of palpitation, no history of syncope. There is no history of puffiness of the face or enlarged neck veins. There is no history of blurring of vision or joint pains. There is no history of bloodletting or phlebotomy. There is no history of abdominal distension or swelling of the face or limbs. There is no history of dyspnea and orthopnea. Birth history. Child is born out of a third-degree consanguineous marriage. He is second by birth order. Delivered by normal vaginal route. Birth weight was 3.2 kg. There is no significant antenatal, natal or postnatal history. Developmental history. The mother noted that the language and social milestones were appropriate for age. There was a slight motor delay. Child goes to school with an average scholastic performance. He's immunized for his age. The last dose he had taken was at 5 years, though no records of immunization are available. There is no history of congenital heart disease in the family. Socio-economic status, it is a family of 4 with a father is a barber by profession, and it comes to Biji Prasad plus 4. Sir, a 12-year-old child who had onset of cyanosis at 6 months of age with one episode of seizures at 1.5 years of age, underwent a surgery at 1.5 years of age with relief of cyanosis for a period of 2 to 3 years, advised second surgery in future, lost to follow-up, now admitted for the second surgery. With dyspnea, NYHA class 3 symptoms and persistent cyanosis.
What surgery you thought you think the first surgery would be?
So since the child presented at 1.5 years of age, I would like to think that it is a palliative surgery since it was done and they were advised that it would be a second and would need a second surgery. It would not have been a corrective surgery. Palliative surgery, I would like to think based on since it was a 1.5 year old child and the onset of cyanosis at 6 months.
Yes, no, it's done from left side.
Surgery is done from left side.
Then how to tell us what surgery?
So I would like to think that it was a BT shunt. Since there is history of
Why would anybody do a PT shunt in 1.5 years of age?
yes, if the child presented, it could be there could be 3 reasons why BT shunt is done. One is it could be a case of tetralogy of Fallot, where straightforward intracardiac repair could not be performed, like a small branch PA artery size may not be favorable, left ventricular size may be small, or there may be a coronary crossing REOT. At that time, they would not want to do a repair. Or it could be a condition which would require an RV to PA contour, which they could not put at 1.5 years of age. So they would have done a BT shunt.
Our patient will be sick also.
Our patient is sick since child had a episode of cerebrovascular accident, and there could be some relative contraindication for cardiopulmonary bypass. Or it could be a case of single ventricle physiology, which needed a BT shunt so that they could not do a Glenn shunt. Single ventricle physiology, where they could not do a Glenn shunt directly because of small branch PAs. Hence, they would have done a BT shunt and staged single ventricle palliation in the next future. These are the possibilities. Multiple VST, single ventricle physiology, non-rootable VST.
Very good, very good. So, what are the other surgeries that are possible to left thoracotomy?
So, the surgeries to left thoracotomy can be divided into therapeutic and palliative. Therapeutic surgery, palliative surgeries are a BT shunt. We can also do unifocalization through the left side. We can do a PA banding through the left side. Therapeutic can be coagulation repair, PDA ligation. Rarely, even heavy anomalous pulmonary venous malformation, if it is there, the venous we can reroute it to the and closed mitral valvotomy can be done through the.
So, the history was very enough given most of the information out there. What about the emergency function class in this case?
Sir, right now the child is in emergency class.
So, what are the fallacies of the emergency class between cyanotic and emergency?
Sir, in children, cyanotic congenital heart disease, the cause of breathlessness, there is a fixed, there are 2 components, fixed and dynamic obstruction. So whenever they exert,
He is asking what's the fallacy?
fallacy of NYHA.
You are asking explanation. In congenital. Can you ask in general and in particularly cyanotic? You know the other cyanotic also.
NYHA, less than ordinary activity, is, it starts with ordinary activity. So they may not have symptoms that are with ordinary activity that would be
Are there any other types of surgery? This was a planned 2-stage surgery, right? So one you said is BT shunt clip, a corrective surgery at a later stage. Are there any other surgeries in congenital heart disease? It can be a planned two-stage or multi-stage surgery.
Yes, sir. This child could have a pathology of pulmonary atresia. We could have done a BT shunt, and now the corrective surgery would be to RB to PA conduit, which will require revisions. All the RB to PA conduits, conditions requiring RB to PA conduits will be.
I don't think you got the question. The question is, are there any other groups of planned surgeries which are done in more than one stage in congenital heart disease? Forget about trauma.
Yes, sir. Single ventricle dilation, where the first stage could be a lens shunt followed by contact completion at 3 to 4 years of age.
Anything else?
PA band followed with no, sir. Child has presented with cyanosis at 6 months of age. There is history of cyanotic spells, which were worsened.
That we are not sure. That neurological episode, we are not sure. Is it a cerebral abscess? Is it a spell, or is it a polycythemic infarct? From your history, what is your most likely? See, these are the three neurological pathophysiologies.
Since the age at which it has occurred is 1.5 years of age, I would like to give possibility of an infarct than an abscess.
So most likely causes an infarct.
Infarct.
CT done, no? CT done. CT done.
Yes, CT done. And CT was done and advised medical.
Why this cannot be a band?
Sir, this child had cyanotic spells, and if there was a PA band, it would not have gone to have.
You are very categorical that after surgery the sinus is improved. What will happen to sinus? With the exception of? So like for example, you do a band in anybody with 85% saturation, the saturation side will also. So you do a band. Patient can have a flat line once you do a band. In some other acute physiologies, where the relationship between the saturation and pubic waves is like a plateau, it goes on plateau. There it may actually improve. That is the only exception. But such amount of clinical improvement is unlikely to be there. So most likely this is not a bad situation. Most likely we are dealing with this. So sir pointed out like what are the other neurological manifestations of cyanotic encephalopathy? One is infarct, you said, abscess we discussed. What else?
Cortical vein thrombosis. And over all.
What is the most important thing that is coming up in the big group? Is there almost everybody? Like you say,
neurodevelopmental outcomes, intellectual disabilities are more pronounced with children having cyanotic, long duration of cyanosis.
Even TGS were operated in time also, they have poor neurological outcome. That's now the kind of against scale of all kind of demand in this stage. So what are the you said there's other CNS manifestations? Are there increased risk of infection?
Yes, they are associated with, first is they may be having syndromic associations where they have their immunity is compromised. Otherwise also they have increased risk of infections.
So like for example, TG and all are known to have increased risk of many episodes. Even immunity is high in TG conditions, but not good for the You said consanguinity, grade 3 consanguinity. So what about consanguinity and congenital heart disease? Does it increase risk of CHD? How much score? So definitely the data is kind of divided when it comes to how much it increases the congenital heart disease. But definitely increases the incidence of complex encephalopathy. Definitely complexity goes by around 5 times. Whereas the risk of having VSD, PD is not so high. That the house is divided. There are multiple data saying it increases, it doesn't increase. Some of the meta-analysis suggested it does increase, but definitely increases in their complex encephalopathy.
to define complex? How to define complex concerning arteries?
Congenital heart disease where total character of the artery and not complex congenital heart disease.
It's used very often, complex congenital heart disease. Complex congenital heart disease is usually
Except PDA and usually the all the complex heart disease as a definition.
as per definition, even Tof is not complex.
Only PDA treated on age, others are complex heart disease.
One of the common questions that everybody should look at will be, what are the causes of cyanotic spills? What are the mechanisms of tracking how it relieves cyanosis and all those things are a difficult question that everybody should know.
Examination. Anthropometer. His height is 134 centimeter. It is less than third centile for age, as per IIT profile. Weight is 25 kilos, less than third centile for age. BMI is 13.5, between third and 15th centile for age. Upper segment, lower segment is 1.05. General physical examination. He has grade 2 pan-digital clubbing. He has grade 2 pan-digital clubbing, cyanosis. There is no evidence of dysmorphism. There is no evidence of infective endocarditis. There is no history. There is no evidence of renal caries. Pulse. Pulse is 92 per minute. It is regular, normal in volume and character. No radial or radiofemoral delay. All both upper limb pulses are well fed and equal. Saturation is 80% in all four limbs. Respiratory rate is 24 per minute, which is abdominal thoracic type. Blood pressure is 106 by 60 in right upper limb and 112 by 64 in right lower limb in supine position. JVP, there are normal A and B waves with normal descents, normal expiratory variation, hepatojugular reflex is negative.
Not really good.
Not elevated.
Not really good. What is the upper limit? Upper level that we see? So what is the upper limit? You say the areas are normal.
Yes.
So what is the upper limit of normal? Just the position did you look for it?
I saw it in sitting only, I got it. I did not getting a 45. Inspection and palpation. The chest is symmetrical, precordium is silent. There is a scar noted on the left lateral aspect of the thorax. The wound has healed well. The apex is RV type. There is no heave or thrill. There is no suprasternal or parasternal pulsations, no dilated veins. Percussion. Left second intercostal space is resonant. Left quarter corresponds to apex. Right quarter is substernal. Liver dullness is on the right side. Tympanic node on the left side. Of the stomach on the
Can you say apical impulse located?
is in the fifth intercostal space at the mid-clavicular line.
And no parasternal heave.
No heaves. S1 is normal. S2 is single, probably A2. No S3 and S4. No additional sounds. Murmur. There are two murmurs. First murmur is a short ejection systolic murmur, grade 3 by 6 in intensity, of mixed frequency, which is early peaking, best heard in the left, third and fourth intercostal space. There is no change with respiration. Second murmur is a continuous murmur, which is of mixed frequency, best heard in the left, second intercostal space in the infraclavicular area. It is also heard in the left axilla. It is also heard in the left suprascapular area in the back. Per abdominal and RS system like normal. CNS is having elaborate CNS examination. Higher mental functions is oriented to time, place, and person. Speech is comprehensive. Cranial nerves. There was deviation of the angle knob to the right. In motor examination, there was wasting of the muscles of the left upper limb as well as the lower limb. There was increased tone, flexor tone in the upper lower and lower limb. There was Power was grade 4 by 5. Sensory system was normal. There was no involuntary movement. Plantar was extensive. Bladder and bowel was normal.
So one side. And diagnosis.
Diagnosis is situs solitus levocardia, cyanotic congenital heart disease, probably Farrett's physiology, status post left modified Bt shunt. Anatomical diagnosis, we like to think first of tetralogy of Fallow, status post Bt shunt. Other diagnosis I would like to still keep is of DORB VST-PS with hypoplastic branch PS, status post Bt shunt. AV canal defect and or single ventricle of RV morphology, status post Bt shunt. In sinus rhythm, not in CCF, no evidence of infective endocarditis. Post sequelae of cerebrovascular accident with weakness of right hemisphere.
Why do you get Tof as your first possibility?
So first is because the child, the onset of cyanosis was at 6 months. Second, till 1.5 years of age, the child without any treatment, there was no problems, and there was an event only at 1.5 years of age. And even now, the child with surgery,
Most likely
diagnosis.
Most likely diagnosis is cyanotic is going to tetralogy all the time. Statistically of the structure. So unless you didn't find anything to suggest that it is not likely to be something else. So what are the other things that you look for? Like for example, what are the causes of cyanotic heart disease LDFX?
So cyanotic congenital heart disease with LDFX, first is tricuspid atresia, single ventricle of LV morphology. DORB with restrictive VST also in our LDFX.
What are the other non-tetralogy conditions with LDFX? Cyanotic.
Not Epstein's cyanotic can have LDFX. AV cannot defect, unbalanced AV cannot defect with an LV morphology.
Another important thing is injectable and pulmonary.
DIS.
DIS.
can also have an
So like two conditions that are non-tetralogy, Epstein and DIS. And rest of them not like that. When do you clinically suspect DORB VST-PS?
Clinically, we suspect DORB VST-PS when we have a clinically we suspect when there is a harsh murmur and worse cyanosis.
Why? Why is this so? You are very right. Like you are absolutely right. So why is that so?
So in DORB there is unfavorable screening, because of which, despite there being good antegrade flow, there is still worsening of cyanosis.
So, for example, what are the hemodynamically, what are the three conditions that can produce cyanosis? In general.
Harsh murmur, worse cyanosis.
In general, what are the hemodynamics of cyanosis in our disease?
There are only three methods I did cyanosis and
What are those?
three methods? What are those three methods?
One is admixture physiology, admixture physiology.
Omnestic right to left.
So one is omnestic step down, happening from at the ventricular level or at the aortic level, either because of PS or PH. So that's your first one. So second one is usually admixture. Third is
Transposition.
so transposition. Here what you are suggesting is instead of step down happening, with the increased flow also, good amount of flow also, there is more cyanosis. That means something else is at play. Either admixture physiology or a transposition physiology. When do you suspect AVSBPS?
Sir, in history-wise, if there is history of palpitations, if there is history of episodes of syncope, then on examination if you get evidence of AV regurgitation, heart failure, complaints of heart failure.
Very good. So suppose, what are the other conditions in which you have episodic palpitations in cyanotic heart?
So CCTGA will have episodic palpitations. AV canal defect can have episodic palpitations. Heterotaxis can have episodic palpitations.
And also
Epstein's anomaly can have.
I think Epstein can be one first.
So what will you diagnose CCTGA with GPS in this situation?
CCTGA, the onset of cyanosis is not so early. It's the valid circulation. So they do not present early in
May not
infancy.
present so.
Yes.
Yeah.
Even if they present then they will
That's okay. One point. What is clinical examination?
clinical examination and look for L-post error, which would suggest it's
Anything
and
else?
AVVR.
Anything else?
Syncope, again, palpitation, syncope.
Anything else?
Not syncope.
Whenever you find a situs versus heart position,
Dextrocardia.
so whenever you have situs solidus and dextrocardia, situs inversus and glucocardia, it's a CCD. Whenever the alignment is abnormal, then the commonest possibility of doing this is. What is the cause of continuous movement in cyanotic infarction?
So, one could be a case of heterology of fallow with multiple aortopulmonary collaterals causing continuous movement. It could be a status post, it could be a PDA, status post Bt shunt. Not continuous, but to and from other can be in PSP or absent pulmonary.
Anything else? What are the other causes of continuous movement in cyanotic infarction? You are a pediatric analyst, so you have to know a bit more. This much is okay for
Vascular stenosis, right heart.
So, cyanotic with
cyanotic is continuous movement.
Vascular stenosis, right level. Truncus?
Truncus and
No, what individual person on Truncus? Truncus, why do they function about Truncus?
You get a continuous movement commonly with common current truncus, you see, do you get a continuous movement? You don't.
We won't get it.
But when do you get it? Static pressure. You don't get a continuous movement. When do you get it?
Yes. There will be a gradient between the aorta and the PA.
So what anybody else wants to add to this, like cyanosis with continuous movement? It's quite okay, like you going the common ones, some of the uncommon ones. Generally you don't find such a continuous movement, but all pulmonary malformations can produce a continuous movement. May produce continuous movement. So other thing is the venous thumb over TABC have been described. In TABC also you can get a venous thumb like movement. And then rarely you can get a continuous movement at the ASD level in this condition. Mitral atresia with ASD, restrictive ASD, you can get a continuous movement there. So these are the ones that you just for additional purpose. So S2 is a common question, but S2 is said most likely to be A2. So why do you say this?
The background of sciences, taking all the other things into consideration. I think the second half of this is not heard in the combining all the other clinical features and the backdrop of the case. I would like to think that it is.
Why people absent here? Why people absent?
There is no consciousness related to blood flow. Severe with valve please. Either the P2 is soft, not right.
Why they say mobile? Take mobile. Take mobile.
What would you like to see? X-ray or
Variants of those.
And we have the ECGs.
With the ECG, what one diagnosis is definitely ruled out with your findings? Anything else? What about pulmonary disease? Pulmonary disease was high in the list from the history. Is the pulmonary disease a very important possibility? So
There's
there's
an
a
early ECG with normal standardization, showing the normal size. heart rate is about 120 per minute. QRS axis is right axis deviation about 110 to 120
That's
degrees.
why I told the right.
There are tall monophasic waves in V1, followed by deep waves in V2. And atrial enlargement, there is no evidence of any atrial abnormality. And RBH. ECG. The loop is clockwise loop. Consistent loop.
Foundation 2 is usually wanted to utilization because every is underpaid. So we are getting 3 training.
So it is status for Bt Shunt. So there will be some small tube waves.
Why this is early transmission?
So, just a slightly rotated film. Showing the cyclosis solidus, how much was it on the left and liver shadow on the right. Bronchial cyclosis solidus. There is no cardiomegaly, CT ratio of 0.5. Apex is RV. There is no evidence of right atrial enlargement. The pulmonary bay appears to be empty. And the vascularity seems to be
Aortic arch,
aortic arch is right sided.
Any other one? Any other thing? Something is striking at you.
Only ECG is not well,
What about IGP and LPA?
RTPA is a
What is height? You can break IGP. What is height of
I see
IGP?
no nice only.
It looks hypoplastic. What about LPA?
this one. In comparison to the right bronchus,
PA is 1
And they are traveling with left side, traveling with
is routing of the ribs on the left. There are
traveling with what? What is it?
if the other was crapotomy, it is a sequelae of
Traveling.
this. There are different populations to one more.
I think LPA is slightly more dominant. LPA is bigger than RPA. LPA is much bigger than RPA. Yes. LPA also seems to have a slightly higher RPA.
Subcostal view with color interrogation showing cytosis solidus. The IBC is uninterrupted and entering the right atrium. The base apex axis is pointed towards the left, suggestive of levocardia. Probably bicable view for to show intact IAS. color interrogation showing no shunt across the interatrial septum. Apical four-chamber view showing AV concordance. There is a large phonoventricular VSP, which is
How to know government based this?
Inside of
apical five-chamber view showing a large phonoventricular VSP. Predominantly shunting from right to left. Parasternal short axis view showing there's a large unrestricted VSP, anterior and septal deviation of the conal septum causing infundibular stenosis. The infundibulum is narrow. Pulmonary valve annulus looks small, but the branch PS look adequate size.
Explain RPA.
Yes. LPA is particularly bigger than RPA.
Do you think we develop the SOK of British Shunt?
Yes. Because the goal is to keep the BT shunt as close to the confluence as possible. But sometimes if it is slightly distant, then unilateral PA slightly can be.
That means stenosis also.
What about coronaries? Are you able to see some coronaries here? Is it normal?
There is no coronary crossing REOT. There is one coronary here. I'd like to place the close, but since the aortic root is ratio rotated to the left coronary, so we realize that it's normal case. The gradient across the R524 outflow tract was about 90, which was severe infundibular stenosis. In order to demonstrate the side of the arch, to demonstrate first branch towards side, which side it is going up forwards. Since the diagnosis is pathology of fallow with it is called BT shunt, and the valve annulus is small. I'd like to calculate the Z-scores of the pulmonary valve annulus and Z-scores of the branch base. They look very good. Let me delineate the coronary arteries. Like assess other things, that is the presence of additional VSPs, branch TA sizes, presence of collaterals, and once if this pulmonary valve annulus is less than -3 Z-scores, then you would like to send it for surgery with a transannullar valve and take down of the BT shunt.
What are the imaging? What are the imaging?
CT scan would be done in order to delineate all.
Although all the things that you told, which one is it's not good for us. So you said that this was the reason why we need more imaging. So for everything else it is okay, but except for one thing. How good is CT for picking up additional VSPs?
Additional VSPs, better picked up assessed on echoes with the
Economy because then especially for economy also.
the angiogram.
Suppose if this patient comes to you right now, not 10 years back, what do you do with that? Same situation. Patient had a recent stroke, this neurologically disease, but have severe kind of. What do you do? Because these are vocal correct, so correct.